Good morning, everyone. Today we are going to discuss portal hypertension, and many of the things in this lecture will be repeated because, like you have done this portal hypertension in medicine, so it will be like more or less the same thing. But of course, like in this one, in this lecture, we are going to uh, keep in focus the surgical management of portal hypertension. That is esophageal varices or esophageal bleed, which occur as a result of portal hypertension. So, starting with the discussion, which in my first lecture I already told you that the portal venous system, it contributes around 75% of the blood to the liver. So, and how the portal vein is formed? Of course, it is formed uh, by the vessels which are coming from the, you can say the intestines or the GIT, the superior mesenteric vein, and also it receives a splenic vein. You can see like over here, the splenic vein is coming, and all this uh, blood supply from different like superior and inferior mesenteric are veins, and they are forming the portal vein. So now in adults, around 1 to 1.5 liter per minute of portal venous blood is supplied to the liver. So every minute the liver receive around 1 to 1.5 liters, or you can say 1000 to 1500 ml of blood, portal venous blood. Now, one thing which occurs in the patients of cirrhosis, this amount of the blood is increased. Okay, and a few of the things, for example, the portal venous system, there is no walls in it. Okay, so it drains the blood from the spleen, the pancreas, and the gallbladder, and the intestines, right? So now, the important thing here is what this circulation, or the portal circulation, or the portal vein, uh, it communicates with the systemic circulation at certain points. Okay, one of that systemic, um, you can say, yes, this one. So one of like, see, this is the portal vein, and this is sending some tributaries here to the esophagus, and uh, the systemic veins, they are communicating with the portal veins, right? Or simply, in simple words, you can say that there is a portosystemic anastomosis, right? So this is our point of discussion, like this is our point of focus, you can say. So there is communication of the portal circulation with the systemic circulation at gastroesophageal junction. Also, there is a communication in the anal canal. There is some communication in the falciform ligament, okay, and also in the splenic venous bed. So now, to show you again, see, this is like the more extensive demonstration of this thing. Here there is a portal vein, and see, it is sending tributaries here, here and here and also here, right? So simply see there is a gastroesophageal junction anastomosis or communication, anal canal, some in the falciparum ligament and splenic venous bed. So there is a lot of communication, and also left renal vein was also communicating with this. Okay, so this slide also, of course, like have a lot of other information available, but of course, like I'm going to talk about the important points because we have to cover this thing in this lecture. You can see, okay, this is the intrahepatic course of portal vein. You can see over here the portal vein is there, and then there's portal canal, then there is hepatic sinusoids, and then there is a central vein. Okay, of course, like the central vein collect all the blood from different parts of the liver, and they form hepatic vein, which ultimately forms the inferior vena cava, right? So you can say this is one segment of or a functional unit of the liver, like the blood from the portal vein, it comes and uh, this one basically goes to these hepatic sinusoids and ultimately it reaches to the central vein, and the central vein collect the blood, send it to the bigger veins like hepatic vein, which join together. If you remember, there are three hepatic veins which join together and form inferior vena cava, right? So now the points here to mention is what is portal hypertension? The normal portal venous pressure is around 5 to 10 millimeter of mercury, and this is the pressure where very little blood is shunted, basically from the portal venous system into the systemic circulation, right? What I mean to say is, like, of course, like going back to our previous slide, which is this one. The pressure is so low, you can say, like in normal circumstances, very little blood will go and will shunt into the systemic circulation over here, or to the all other places, right? So this what occurs in the normal people, right? But um, if the portal venous pressure increases, okay, like this pressure will increase, then of course what will happen, um, then more and more blood will go into the shunts, okay, or into the systemic circulation. And ultimately, when there is more pressure over here or over here, what will happen, of course, like these veins are going to dilate, and more blood will be shunted into the systemic circulation, okay. And there will be dilatation, and it is believed that nitric oxide is the main mediator of this thing. So this is the point, uh, you can say, whenever there is portal hypertension, uh, what is the thing like which happens, right? And it creates all the problems. So uh, now the portal venous pressure, which is around 5 to 10 millimeter of mercury, is basically greater than the inferior vena cava. Okay, but as this pressure increases, we call this thing as portal hypertension. And so, see, portal hypertension is a frequent clinical syndrome, and there is increase in the portal venous pressure, and it is often defined as portal pressure gradient of 10 millimeter of mercury or greater. So, and the most common reason for that is, of course, liver cirrhosis. people who have liver cirrhosis, they have increased, what you can say, portal pressure. Let's see a case. A 45-year-old male was referred to the hospital due to hematemesis and melena. Like, what is hematemesis? Of course, like uh, vomiting blood. He was known for about 8 years with viral hepatitis HPV. And on admission, the blood pressure was 93 by 58 and heart rate was 112. What they wanted to show you here is like hemodynamic instability. Like the blood pressure is increased and the pulse is increased. So the patient is in shock. Physical examination revealed anemia. There is abdominal distension, like which means like ascites, and distended veins around the umbilicus, and spleen is palpable. So that is basically a very, very clear-cut scenario of someone who had already developed cirrhosis. A chest X-ray and ECG showed no abnormal findings. Labs show white blood cells reduced, RBCs reduced, hemoglobin, platelets, AST and ALT of the values, and prothrombin time and activated partial thromboplastin time and total bilirubin, AST and ALT levels, and albumin. So like these are all the labs to check the liver function test, and we had already discussed that. And he was hepatitis B surface antigen positive. Okay, HBE positive means what? Like, of course, it shows infectivity. So he's like uh, developed some serious damage to the liver. So now you can see over here, if we will classify portal hypertension, so it can be classified on three types according to the location: prehepatic, like before the liver, which is the portal vein, and there is increased resistance in the extrahepatic portal vein. For example, uh, people who have portal vein thrombosis, this is the most common one, then infection in the abdominal cavity, hepatic arteriovenous fistulas, and neoplasms. Okay, and then there could be intrahepatic or liver causes, like when there is increased resistance in the microscopic portal vein tributary, sinusoids or small hepatic veins. Now you can see it could be pre-sinusoidal, it could be sinusoidal, it could be post-sinusoidal. We are talking about the sinusoids, okay, hepatic sinusoids, and so it could be pre, it could be like in the sinusoids, it could be post. Now, pre-sinusoidal like chronic cholangitis or schistosomiosis, and sinusoidal, of course, cirrhosis will come because what is cirrhosis? Cirrhosis is basically fibrosis of the liver, right? And simply, in simple words, you can say that the normal liver tissue is liver cells, they are replaced by scar tissue or fibrosis, fibers, So the liver parenchyma is all destroyed, right? So it cannot cause anything. So, and it could be post-sinusoidal, like veno-occlusive disease, of course, like if there is any, you can say, for example, if this one is blocked, what will happen? That, or if this one is blocked, the central vein, so what will happen? The fluid will start building here, which will give back pressure over here, and ultimately there will be increased pressure in the portal vein. Okay, so there will be back pressure simply because the drainage is blocked, right? So that is basically what will happen in the post sinusoidal. And post hepatic is like after the liver, so it could be obstruction of the large hepatic veins and or the inferior vena cava, or for example, someone who have right heart failure. In right heart failure, what happens? Like the liver get enlarged, and simply um, uh, to tell you about this one, of course, the liver drain the blood into the uh, central vein, which together form what inferior vena cava. Inferior vena cava drain into the right atrium, and simply when there is right atrium is not working fine, or the right heart is not working fine, so again there will be back pressure, like you can say, pulling up of the blood into that circulation, which will ultimately cause pressure on the liver, right? So you can see, like, they have given you the heart failure, massive splenomegaly, constructive pericarditis, and Budd-Chiari syndrome. So what is Budd-Chiari syndrome? Basically, Budd-Chiari syndrome, and in the bracket it's written hepatic vein thrombosis. It's more common in females, and uh, what happens, basically, they have a thrombos formation, or thrombosis of the hepatic vein. Um, so what happens, like, when there is obstruction of the, or thrombosis of the hepatic vein, so simply there is outflow obstruction, there is obstruction to the outflow, to the drainage, and the blood will start pulling up in the liver, or you can say the liver will be congested. So simply that give will damage the liver cells, liver functions, and it will develop into portal hypertension. And uh, remember, guys, uh, we know what is ascites. We know already what is esophageal bleeds. Okay, these are all manifestations of portal hypertension, right? Whenever someone have portal hypertension, so these are all manifestations of that. Okay, so this is basically Budd-Chiari syndrome, and whenever we are dealing with any patient of Budd-Chiari syndrome, what we have to do, we basically do, you can say, the full screening, or what we call it as thrombophilia screening. There are 7 things, protein C, protein S, antithrombin, and many others. Okay, we check them. Because they have some size, some sort of hypercoagulability. So when they develop a hypercoagulable state, so what happens is, that leads to a thrombus formation, and that is the one which block the hepatic vein. So this thing can be done, and of course, like, other investigations for the liver structure and liver functioning can be done. Okay, and I have already discussed what is the structure test for the liver structure, what are the tests for liver functionality, right? So this is what happens in Budd-Chiari syndrome. Okay, and ultimately, of course, like, we are discussing portal hypertension now, so ultimately they will develop portal hypertension, and they will be having all these things. So um, now, how we treat that, of course, we will discuss that thing um, later on, right? And um, other than that, okay, now they are talking about the pathophysiology in this slide, and you have already covered this topic in internal medicine. That's a good point, and I'm sure, like, not, if not all, but many of you already know what's the pathophysiology of this thing, right? Um, the important thing here is, uh, remember the signs and symptoms of, which we'll discuss now, the portal hypertension. Okay, and if you know the how there is, where is the shunting, or what are the regions where there is shunting of the portal and the systemic circulation, things will be easy to remember. Like, if you know it's in the esophagus, so esophageal bleed, in the anal canal, in the spleen, and so, like, it's very easy to remember the things if you know the basics. Okay, Uh, now, varices will be formed in the esophagus, varices will be formed at the anorectal region, spleen will be enlarged, and of course, um, when we examine the patient on the abdominal wall, um, what you can say, there are some veins which are visible in the patient, around the umbilicus in the radial fashion. So when the flow in these umbilical veins are too much high, so we call this condition as caput medusas. Okay. Now, um, going further, um, the pathophysiology is simply, these patients, they have increased portal vascular resistance, okay, as well as increased blood flow. So when the resistance is more, the blood flow is more, so of course the portal pressure will be increased, okay. um, and Ohm's law states the same thing: portal pressure is equal to resistance multiplied with the blood flow. Okay, so sorry, there is a lot of spelling mistakes in this one. Okay, now uh, okay, okay. So now, uh, like, if you understand this point, like, there will be increased blood flow, there will be increased blood resistance, okay, and the portal veins are anastomosing or shunting in the systemic circulation. So simply, this portal venous collaterals will divert the blood into the systemic circulation, and there will be hyperdynamic portal venous circulation. And of course, it relates to how much liver is damaged, right? Or whatever is the one which is causing this portal hypertension. So ultimately, what happens? The cardiac output increases, and arterial blood pressure is normal in these patients. Okay, and there are many other, what you can say, vasodilators and vasoconstrictors also play a role in that, but I'm not going to in that much detail of this thing. A very good demonstration of cirrhosis, increased hepatic resistance is there, right? So what are the mechanical effects? Of course, like, there is fibrosis, there is vascular occlusion, and there is endothelial dysfunction and increased vascular tone, and there is increased blood flow, increased pressure over here, and more blood will be shunted here. Okay, and I told you nitric oxide is the main mediator of all those things. Okay, so now, uh, considering, for example, someone have portal hypertension, right? What will be the complications of this thing? So, from surgical point of view, of course, we will discuss in this one. First of all, of course, they will develop varices, right? They will develop anorectal varices. They will develop esophageal varices. Okay. Maybe I don't think so I have any diagram over here, but what I can do, which I always do, is I can take the help of Bing and Bing.com, and maybe I can show you um, a few of the things over here. Okay. Uh, Sorry. Wait. Okay, let it wait to open, and then until then, we will continue this lecture. Okay, so one of the complication is the formation of varices, and then there is ascites. Now, what is ascites? Ascites is simply collection of extra fluid in the abdominal cavity. Okay, Now, simply, any patient who have ascites, you will found that their tummy is very distended, right? Because there is extra fluid inside the tummy. And if you remember from that physical diagnostics, that we do a fluid thrill and uh, shifting dullness. We do it for that thing. Okay, so esophageal varices. Okay, so maybe we can found something. Yes, you can see over here. Very okay. So I'm just waiting. I don't know what's wrong with the internet, but I hope it will work. Or I can show you over here. Okay, so I will give it some time to open because I don't know what's wrong with the internet. So okay, and spleen will be enlarged, okay, as well. So ascites, varices, and spleen will be enlarged as well. So from surgical point of view, what we are going to basically pay more attention is to the varices, because it can result into the bleeds, okay, and other things, how we can manage the patients of ascites, right? Uh, so going on, what is varices? Normal portal pressure is 5 millimeter of mercury. When the pressure is more, of course, it results into the development of varices, and when the portal pressure is more than 12, it can lead to variceal hemorrhages. Okay, you can see over here. Uh, I don't know what's wrong, so I'll leave it, close it. Okay. Okay, so uh, esophageal and gastric venous plexus. So we had discussed this thing, right? And this is ascites. See, distended abdomen, and there will be a lot of leak of, because simply there is back pressure, or there is congestion of the portal systemic or portal blood or circulation. The fluid is going to leak out in the abdominal cavity, and it will collect in the abdominal cavity, which will result into ascites, right? And because the liver is not functioning fine, so the liver cannot form albumin or proteins, and that lead to reduced oncotic pressure inside the circulation. And proteins are very important to hold up the blood into the uh, inside the vascular system. But once the um, there is less proteins in the blood, so the oncotic pressure is reduced, so of course, like, the fluid will leak out. And once the kidneys, they sense that there is less fluid in the circulation, so what they do, they keep on retaining the salt, okay, because of high levels of, or the activation of RAAS, or renin angiotensin aldosterone system. Okay, so they have high aldosterone levels, of course. So this thing, so one of the manifestation is varices, and one of the manifestation is ascites, and one of the manifestation is splenomegaly. So simply, because of increased portal pressure, it can cause splenomegaly as well as hypersplenism. What is hypersplenism? Of course, the blood will pool in the spleen, which will lead to increased destruction of the cells, which is called as hypersplenism. And that's the reason it can cause pancytopenia. And if you will pay a little attention on the case I show you, so in the labs you can see, like, the WBCs as well as the RBCs, and as well as the platelets, they are all reduced. So that is as a result of hypersplenism. Okay. Now, the patients can present with distended abdomen due to ascites, splenomegaly and hypersplenism, so anemia, infections, all these things. The liver is not functioning fine, so hepatic coma, and hematemesis or melena due to the bleeding of the varices, right? And rest, gynecomastia and reduced hairs here on the chest. These are all the consequences of the liver failure, right? So this is how the patients are going to present to the doctors, right? So now, once you have understand this thing, uh, now we are going to discuss in more detail, uh, how to prevent variceal bleeds or how to manage variceal bleeds, right? So the diagnosis of portal hypertension is generally not diagnosed until systems of progressive hepatic dysfunction or cirrhosis develop. And once the signs and symptoms started appearing, then of course our investigations are more directed towards to know how much damage is done or what is the extent of the hepatic dysfunction. So of course you will take history, as you know, hepatitis B, C, alcohol, Bacchiari, whatever is there. So in the history, of course, jaundice, transfusions, any hereditary liver disease like hemochromatosis or Wilson's disease, alcohol use, and any hematemesis, melena, all those things can be seen. Then physical examination, we will see the signs of liver disease. We will see the dilated venous abdominal wall, caput medusas. We will check rectal hemorrhoids, ascites, jaundice, and splenomegaly, right? And then we will go for the labs. We will do all the basics, CBC, RBCs, WBCs, and platelets can all be decreased. We will send the patient for liver function test, which will check the bilirubin level, ALT, AST, as well as uh, GGT, gamma glutamyl transferase, and alkaline phosphatase. Also see the albumin levels. We will check the clotting profile, and prothrombin time. All these things is, it comes in clotting profile, and then of course we will go for uh, the other investigations which can cause cirrhosis, like hepatitis B or C serologies, and if there is ascitic fluid, you can do that. You can take that. You can see if there is any infection. Uh, because ascites can be formed, like can be due to tuberculosis even. Uh, okay, we can do a liver biopsy, by the way, ultrasonography. So all the studies to check what is the functionality of the liver, or you can do this thing just to find the cause of cirrhosis or ascites or portal hypertension. And I show you many causes like um, prehepatic, hepatic, and posthepatic, like Budd-Chiari syndrome or cirrhosis or all these things, right? So, see, this is all diagnostic evaluation. So you can do CT scan, you can do X-ray with barium swallow to look for the varices. We can go for an endoscopy. Endoscopy, of course, they put a pipe from the mouth and they go to the esophagus and they see the varices. I was trying to show you that, but again, I will try to see if we can see now. But uh, 4 plus, okay. So all this thing is diagnostic evaluation, and I already explained what is Child-Pugh score classification system for liver dysfunction. So it is to calculate the mortality, okay, and see, it is no need to remember this one, by the way. 1, 2, 3 points, and albumin ascites is present or not, bilirubin encephalopathy is present or not, and prothrombin time. And we divide into, we can say like the patient is having is class A or class B or class C, depending on how much points they are getting. Of course, the maximum could be 15. So class A has favorable prognosis, whereas class C is at high risk of death. Okay. So the effective treatment is basically, it could be non-operative as well as operative treatments, right? So of course, like we must pay more attention to the operative treatments, but non-operative treatment. See, non-operative treatment is basically, of course, if you found some cause of ascites or portal hypertension, which is treatable, you treat that, of course, right? But if the cause is not treatable, then you will give some treatment to decrease the chances of complications. Like varicose bleed is one of the complications, right? So, uh, what we do, by the way, to prevent varicose bleed, first of all, we will ask the patient to stop using alcohol, stop using the drugs which can increase the chances of bleeding, like don't take NSAIDs, don't take aspirins, and we give them propranolol or nadolol or beta blockers, you can say. Propranolol is, a non-selective beta blocker. And beta blockers basically reduce the chances of variceal bleed, and they also reduce the mortality. Like these are the studies which show this thing. Some of the patients, they don't respond to these beta blockers. Okay, so these things can be done, and these one are basically to stop the bleeding. So anyhow, same thing, non-operative treatment. Okay, I think it's better to discuss in surgery what you have to do once the patient started bleeding, or the patient is presented to the emergency with variceal bleed. Okay, so what happened, by the way, many patients who have liver cirrhosis, but basically they don't know they have liver cirrhosis, their first presentation to the hospital is basically bloody vomiting or hematemesis. So of course, like any patient who will come to the hospital with hematemesis, it could be a small bleed, it could be a big bleed. First of all, we always go for ABC, airway breathing circulation. We secure 2 IV cannulas, and then depending either the bleeding is stopped or depending either the bleeding is still going on, we decide according to that. We send a call to the blood banks to arrange blood. We admit the patient into resuscitation room or in ICU, and depending on the hemoglobin levels, we decide either they need a blood transfusion or not. Okay. Sometimes we can give the patients fresh frozen plasmas, platelets, or vitamin K infusions to stop the bleeding. Now, uh, so see, clear airway. Many of the patients, they are at risk of getting infection, so antibiotics also. Okay. So these things can be given. One of the things which we give is basically, okay, beta blockers, as I told you already. One of the things which we give is somatostatins or octreotide. It decreases the portal venous pressure without any effect on systemic hypertension or systemic circulation. We can also give them vasopressin. Now, vasopressin is mostly given IV at the dose of 0.2 to 0.8 units per minute, and it's a vasoconstrictor. Okay, it's an intense constrictor. Okay, so of course, when it decreases a vasoconstrictor, it decreases the mesenteric blood flow and portal pressure. And all these treatments can be given to the patients. These are pharmacological or drug treatments, So, because we are studying surgery, so now we can send the patient directly to endoscopy. So, endoscopy should be performed as soon as possible, guys, because it is the one by which you can directly see from where the bleeding is coming out, and basically we can uh, do a lot of manipulation, you can say. Okay. So what we do, by the way, um, they go for an endoscopy, and they can do a sclerotherapy, in which like they inject a sclerosing agent into the bleeding varices to obliterate them, or they can ligate that vessel, which is called as variceal ligation. If the bleeding cannot be stopped by that, then we can put a Sangstaken, the full name is Sangstaken Blackmore tube. So what is, see, you can see this tube, like what they do, they put it inside the esophagus, and once they reach to the required place, they inflate these balloons to cause pressure, to do give a tamponade effect, and to stop the bleeding, right? So these are minimally invasive, you can say, less interventional. Not it is invasive, of course, but it is less interventional. Of course, you are not opening anything, but you are trying to stop the bleed. Okay, one of the things is called as TIPS, that is transjugular intrahepatic portosystemic shunting. Now, what is this one? See, this one is the hepatic vein, and this is the portal vein, as you can see over here. And what they are doing, see, they put a shunt. Like simply to reduce the pressure into the portal circulation, they put a shunt. So, of course, the blood from the portal vein will directly go into the inferior vena cava, or the hepatic veins. So this is called as TIPS, or a transjugular intrahepatic, like in the liver, portosystemic shunt. So you are creating a shunt. Okay. Now, uh, this procedure is used in emergencies management of variceal hemorrhage. Okay. And any patient who is bleeding and who is not responding to the endoscopic treatment as well as to the drug treatment, this shunt can be placed under local anesthesia, okay, or under the ultrasonographic guidance. So what they do, through the jugular vein, they go into the superior vena cava, and then they take that guide wire to the inferior vena cava, and they reach the hepatic vein, and through there, they put this shunting into the portal circulation. So simply they insert this shunt, okay, which shunt the blood from the portal to the systemic circulation. So this is like what they do. Okay, it's a metallic stent, and it gives a very good control of the to the hemorrhage. Okay, it can stop the hemorrhage, but of course at the expense of many complications. For example, one of the complications is simply because now this blood from portal circulation is shunting into the systemic circulation without passing through the liver. So what will happen is basically this blood is now not no anymore detoxified by the liver, which will introduce the toxic substances into the systemic circulation, and it can lead to encephalopathy. So we call it as post shunt encephalopathy. Okay. So and there are many other small type of complications like damage to the liver, damage to the joining structures. Okay. But simply, in simple words, you can remember that uh, it can lead to what? It can lead to the worsening of encephalopathy or development of encephalopathy. Okay. So this is called as tips. So the same thing which I explained, in hepatic encephalopathy, occlusion can occur of the stent and rebleeding can occur. Now comes to the operative treatments of this one. So one of the operative treatment is, of course, development of shunts or surgical shunts, you can say. And one of the things is devascularization operation, and the last and the ultimate solution is, of course, liver transplantation. Okay, before explaining more these things, I want to tell you that nowadays these shunt procedures are not done much because tips was introduced in 1980s. Okay, and after that, for the last 30 years, you can say we don't have to do the open surgeries because tips is a less interventional type of thing, which you can do. So uh, and also because of successful liver transplantation nowadays, now these procedures are not too much done. But of course, like we are studying surgery, so you must know what are the options which are there. So see, non-selective shunts you can see over here. What is the main point is, like, you have to create the shunt. You have to divert the portal blood to the systemic circulation, right? This is one of the things. Um, so uh, you can see over here. Um, End to side portocaval. See, they are shunting the blood. Okay. Side to side portocaval shunting. Okay. This one is interposition. They are shunting the blood to the systemic circulation. Okay. And this is conventional splenorenal. Okay. And of course, it will lead to encephalopathy. Of course, because the blood is no more passing through the liver. So these shunts, surgical shunts, are very effective method to prevent the bleeding because they reduce the portal pressure and they divert the blood to the systemic circulations. Okay, so selective, which is splenorenal, and non-selective, which is portocaval. Okay, so all the shunts can be done to shunt the blood from the portal circulation to the systemic circulation simply. Okay, you can see the portal blood is coming and going to systemic circulation. The portal blood is coming and going into the systemic circulation. Okay, and the portal blood is coming in into going into systemic circulation, and again splenorenal. The portal blood is going into the systemic circulation. So these are the operative managements, and these are the selective shunts. Uh, Splenorenal, you can see over here, the blood from the spleen is diverted back into the kidney. Okay, and the goal is to prevent vessel bleed. Again, the same story: prevent horrible encephalopathy in this case. And mechanism is decompressed gastrosplenic compartment, maintains portal hypertension in the portal bed. And types is the distal splenorenal and the left gastric vena cava shunt. So these are selective shunts, but the good thing about this one, uh, the blood from the portal circulation still goes to the liver, but of course, like it will keep on resulting into the ascites formation. And these are the partial shunts you can see over here, in which the portal vein and is shunted towards in the inferior vena cava. Okay, and again, this is the devascularization operation or surgery. It is esophagogastric devascularization. So they just divide the vessels, right? Transect the vessels, and they what they do is like they do a splenectomy. But guys, the ultimate treatment nowadays is liver transplantation, in which like all those things will be solved. Of course, the patient have to take a lot of immunosuppressants and things like this. Okay, very major surgery, need a donor, have a lot of complications, but better standard of life, right? So, of course, liver transplantation is the ultimate treatment. Okay, so this is our orthotopic liver transplantation, in which like they put a liver. Okay, uh, this is a donor hepatic artery, which is connected to the celiac artery, and all the things. So the same. So that's all about portal hypertension and the esophageal bleed. So this is like someone who is bleeding from here. They put the Sengstaken Blackmore tube and see they inflate it. Because of the pressure, the bleeding will be stopped. There is a gastric balloon. There is the esophageal balloon. Okay, and they like these are for different purposes. You can see over here. This is sclerotherapy, which I show you already. This is banding. They put a band around the bleeding esophageal bleeds, and uh, this is the tips, and these are the shunts. How they form the shunts: end-to-end shunt, side-by-side shunt, and mesocaval shunt, and splenorenal shunt, and distal splenorenal shunt, and this is a small edge portocaval shunt. Okay, like they put it to inferior vena cava. So that's all. That's all about the portal hypertension, and in this one, the esophageal bleeds are the most important topic which you have to cover. One of the things is ascites. Ascites. It's not the surgeons who treat that, because if someone have ascites and their tummy is too much distended and it is causing a lot of discomfort to the patient, what they do is like they take out the fluid. They put uh, we call it as abdominal paracentesis. So what they do, like they first of all, of course, we try to manage that by the use of drugs, like giving the patients diuretics, right? And if the thing is not solved by that, of course, we can go for abdominal paracentesis. So restrict the salt, give the patient diuretics, otherwise paracentesis, do tips, liver transplantation is the ultimate. And yes, to reduce ascites, again, peritoneovenous shunting can be done. Peritoneovenous shunting. Like they make a shunt so that the blood, the fluid which is collected over here will go directly into the veins. Okay. So that thing can be done to treat such kind of things. So I hope you understand this, and if there's any questions, you are welcome to ask. Otherwise, I will see you in the next lecture. Thank you.